I'd like to welcome you to the national award-winning PRS Journal Club podcast. With your hosts, Dr. Lily Mundy, Raj Parikh, and Kyle Sanniec, this is the PRS Journal Club podcast.
Hi, everyone, and welcome to the January 2019 edition of PRS Journal Club podcast. I'm Raj Parikh, PRS Resident Ambassador from Washington University in St. Louis, and I'm joined by my co-resident ambassadors, Lily Mundy from Duke University and Kyle Sanniec from University of Texas Southwestern. Today, we have the honor of being joined by Dr. Sheri Slezak, Professor of Surgery at the University of Maryland School of Medicine and Chief of the Division of Plastic Surgery at the University of Maryland Medical Center. Thank you so much for joining us, Dr. Slezak, for this PRS Journal Club podcast.
I'm happy to be here.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The article we will be discussing in this podcast is Total Muscle Coverage versus AlloDerm Human Dermal Matrix for Implant-Based Breast Reconstruction. This paper is by senior author and first author Dr. Eric Chang from Fox Chase Cancer Center in Pennsylvania. To quickly recap this paper, the purpose of the study was to evaluate total submuscular coverage versus AlloDerm or acellular dermal matrix coverage in two-stage prosthetic breast reconstruction procedures. This is obviously a popular topic over the years in plastic surgery following publication of the first ADM paper in 2005. The study design was a retrospective review for 3 surgeons over an 11-year period for women undergoing two-stage prosthetic breast reconstruction, with the first stage being a tissue expander and the second stage being exchange for a permanent implant. The study occurred from 2002 to 2013 at a single institution, Fox Chase Cancer Center in Pennsylvania. The authors demonstrated a total of 284 patients who underwent 481 implant-based breast reconstructions, of which 73 patients had AlloDerm and the rest had total submuscular coverage, that the rate of overall complications was significantly higher in the AlloDerm group, being 20% compared to 8.8%, as well as the initial fill volumes, however, being lower in the total submuscular group compared to the AlloDerm group. The authors also demonstrated that the use of AlloDerm added a mean cost of approximately $2,000 for each breast. Their main conclusions were that implant-based breast reconstruction can still be done safely and in a cost-effective manner with total muscular coverage, which was the standard of care previously prior to reports for ADM use. The authors argued that total muscle coverage remains an excellent option, providing quality breast reconstruction without a risk for increased complications and in a much more cost-effective way. So I think this is the time we could get Dr. Slezak's thoughts. Do you use acellular dermal matrix in your practice for implant-based breast reconstruction? There's clearly been a huge cultural shift towards the use of ADM. Do you think it's warranted in every patient? What is your current practice?
When I started in practice, we did total muscular coverage because it was before the time of ADM. But towards the middle of my practice, I've switched and I use ADM most of the time. And I think it has been a significant advance in breast reconstruction. The pectoralis usually ends short of the inframammary fold. And so it can be an inch short or it can be 2 inches short in a short pec. And so it doesn't allow, if you put it just under the muscle, for the implant or expander to sit down at the inframammary fold. So I use the ADM to get better control of my IMF, to tack it into the chest wall and to keep the implant lower. And it also expands better in that lower pole, so I get a more contoured shape. The downside certainly is the cost, and in some studies, the risk of seroma. But I think it's given me such a better result that I use it a lot of the time. Now, that said, in any patient where I have a C-size breast or a ptotic breast, I usually use reduction incisions, and I deepithelialize that lower flap and use it as auto-AlloDerm. So instead of a piece of AlloDerm, I'm using that to span the difference between the edge of the pec and the fold. And the advantage is you have vascularized tissue. So if you have any breakdown of your reduction incision, it's all right. And of course, you save the cost of a synthetic product.
Certainly, and those are wonderful points. I tend to agree with the overall aesthetic outcome, as I think several authors and surgeons have argued over the years, being improved with the use of ADM, specifically with the ability to expand the inferior pole and have a more natural appearing breast in the long term. One of the things the authors didn't do in this paper was look at the long-term aesthetic outcome, but acknowledging that that's a very challenging thing to do in an objective manner. There wasn't also breast Q data included, so the patient's perspectives outside of complications wasn't accounted for in this particular paper. And I think those are two things that going forward, papers that compare ADM to total muscle coverage should really be focused on, as well as the patient experience and patient reported outcomes using the objective breast Q, as well as trying to find a way to report on the aesthetic outcome, whether it be patient satisfaction or just including pictures. Obviously, surgeon-rated aesthetic outcomes have their own controversy. So I think that's certainly something that future papers can focus on. Have you seen differences since you've started using ADM in your own experience with complications, or do you think that the complication rates are pretty equivalent as far as risk of explant, seroma, and then red breast syndrome go?
I saw that they saw quite an increased complication rate, 20% versus 9% in this study. But I have not seen that. I have thought that they'd been very much the same. You know, in a reconstruction, you're always at the mercy of your mastectomy flaps. And if the expander or the AlloDerm is exposed, you're in trouble. And you're always at the mercy of infection. And so if your pocket is colonized, you have two foreign bodies there, both an expander and a AlloDerm, that can be problematic. But I think that can exist in any expander reconstruction. So I would tell you that my complication rates are about the same. I use a drain to prevent seroma, and I put some progressive tension sutures between the AlloDerm and the flap to decrease that, but I have not seen an increased incidence of complications.
This is Lily here. I think one thing about this article that makes it a little bit difficult to interpret their results is that they didn't, randomize patients to either total muscle coverage or use of AlloDerm. And they really only describe using AlloDerm in patients who they were unable to provide muscle coverage for due to damage to the pec muscle and the stratus, which sort of gives you the impression that maybe these are patients that have more aggressive tumors or just sort of a overall difference in their mastectomy. So I'm not sure how much this sort of really contributes to our decision-making process in terms of if we would decide, that this article would sway us to move away from using AlloDerm just based on sort of their methods and how they came about their results.
I also wondered if they got some feedback from their hospital that the cost of the AlloDerm was too great. That's certainly a concern for every institution, and even more of a concern now with the prepectoral placement with the increased use of AlloDerm.
Yes, definitely. I think those are great points, Lily and Dr. Slezak. I think one of the things that is really institutionally dependent in some ways is even the cost of acellular dermal matrix, especially when you are using different products. So I think this study, they used AlloDerm, LifeCell's AlloDerm product, but certainly other institutions use either AlloDerm or any of the other ADMs that exist on the market currently, and those all have different price points. And then there's also different negotiating price points set at each institution for these, depending on how much you use. There are costs in addition, and I didn't really see how they, in their methods, exactly how they calculated that. So that must just be the cost of the institution that the company charges the institution for the ADM product. It seems to be higher than at a lot of other institutions. And I think obviously the size of AlloDerm used also impacts the cost. So when we talk about prepectoral reconstruction and you're using a 20 by 16 sheet, certainly that would cost more than if you're just using a smaller sheet for an infralateral sling. So I think those are other things to take into account. And then I think one other thing is that, as Lily mentioned, it's hard on just a univariate analysis without really accounting for all the covariates to determine whether it was truly the ADM that was predominantly responsible for the complication rates. There were also a lot of kind of uncontrolled factors, beginning with it's unclear if all the surgeons used ADM or it was one particular surgeon who used ADM. And then it's also unclear if ADM was used over just a specific time period. They realized there was a higher complication rate and then they subsequently stopped. So I think there's definitely some selection bias involved as well. But I think it does spark the conversation that a lot of people have had, both at the institutional level, at the surgeon level, on the value of using adjunct ADM in breast reconstruction, accounting for the cost that is obviously there. So how much do you think industry has influenced the use of ADM in breast reconstruction? Certainly a lot of the initial reports on ADM use or with industry-sponsored authors. And do you think these conflicts of interest should be more clearly disclosed and discussed?
I certainly do. I think the pre-pectoral implant placement with the large sheet of ADM has certainly been a topic at many dinner meetings, offered at many meetings around the country or locally, and these are usually sponsored by the ADM makers, and the speakers there are paid considerable amounts of money for their talk. So this is a conflict of interest, and it's always difficult because you certainly want to hear from the people who have experience with the product, but at the same time, the more money they make from that product, the less unbiased they are. So I think that at every talk, there needs to be a full disclosure of whether they are paid for this talk. And, often those conflict of interest slides come up and they're up there for about 1 millisecond and you can't even read the first thing on them before they are taken down. So I think people need to be very transparent about their sources of income if they're giving a talk about a product.
Something that we talk about a lot at Duke at our journal clubs when discussing the breast reconstruction articles often circles back to this idea of cost and idea that many of these women undergo, several procedures or revisionary procedures. Women who are having prepectoral implants or having fat grafting, even our women who undergo autologous reconstruction are sometimes undergoing 2, 3, 4, or 5 revisionary procedures. Do you think it's the responsibility of us as the surgeons to really think hard about how much it costs us to provide sort of what we could consider a comparable level of breast reconstruction for patients? Or do you think that that's sort of going to be forced upon us, maybe by bundled payments or different insurance structures of how insurance companies are going to decide they're willing to reimburse for these types of procedures?
I think that the total cost of any procedure is very hard for us to consider primarily as surgeons because we're really sitting with the patient and looking at them and seeing what would be best for them health-wise, anatomically, and what their wishes are. So cost has always been on the back burner for most of us, but it's coming front and center more and more in every hospital now. So I think we do need more analysis of that. And we have to realize that in all forms of breast reconstruction, it's not just one operation, it's multiple operations. So we need more studies detailing that.
I think that's a great point, Dr. Slezak. And in a broader sense, at UT, when I first started, it was probably an 80-20 split of submuscular with a little AlloDerm sling. Now we've kind of transitioned to probably 60% submuscular and maybe 30 or 40% even doing this pre-pec. I wanted to know what your thoughts are on kind of the young surgeon who's coming out, all these meetings, both plastic surgery, breast oncology meetings, the meeting participants are being bombarded with pre-pec. It's the new thing. It's better. There's no animation deformity. And so that's what's all getting pushed. Patients now are getting pushed to that, and they're coming into CS requesting pre-pec. So what would you suggest for a young surgeon who maybe isn't totally sold on wanting to do pre-pec, but also is trying to build their practice, establish their referral bases, and doesn't want to cause friction with the breast surgeons who are, going to try to send them referrals, and we don't want to really be pushed into the pre-pec era?
Yes, I think especially early in your practice, there's a lot of pressure to offer the latest, newest things and gadgets. But really, you have to evaluate it and see your own results, and you'll always change how you do things throughout your career. But I think communication with your surgery oncologist colleague is very important. And you can discuss with them the pros of each position and the cons. There's a lot of wrinkling with prepectoral, and they often need a lot of series of fat grafting afterwards. It depends on the thickness of the flap, what options you have. And last week I had one of my surgery oncologists say, now I don't want this above the muscle because she's triple negative and she's at high risk for recurrence, and I want to be able to palpate the skin, which was the first time I've heard that.
Having seen both, granted, this is just anecdotes of maybe N of less than 100, but it seems that there is, less post-operative pain. It seems like we're getting the patients up and they're feeling better if you don't go into the muscle. And I also wonder how much that plays into it. I think of it as take off the plastic surgeon hat for a little bit, as a breast surgeon who comes in and sees the patient every morning. one patient is, in considerable pain on a PCA sometimes, if you go under the muscle and then you see a patient who's pre-pec and, they're up, they don't really have much pain, they're feeling great. And so I wonder how much that also influences the breast surgeons then pushing on it, because it's pretty clear when you go into the room for rounds in the morning who had a pre-pec tissue expander and who had a submuscular tissue expander.
Yes, I do think less pain is one of the big advantages, and the lack of animation deformity. But you still need thicker flaps to be able to do it. And I think it's fabulous in older patients that you don't want to interfere with their motion or their life much. So I use it very selectively, but it's another great tool to have in your toolbox, and you may use different things for different people.
Do you do anything to evaluate the mastectomy flaps before if you decide to do pre-pec, whether it be intraop angiography, Wood's lamp, or just your clinical examination?
I use only a clinical examination. I've worked with about 20 different surgery oncology surgeons during my career, and you get to know the ones that make good flaps and the ones that don't. So I may have to use that selectively, but I have some great surgeons that I'm privileged to work with who have very reliable flaps, and I just don't need to do that.
Becky, I think that's a great point, especially for those of us that are still in training. When you start out and you're unclear exactly the results and the thickness of the flap you're getting with the mastectomy surgeon, that if it is available, if your clinical judgment isn't as experienced and you're not as experienced working with your team, to potentially use adjunct technology if needed, at least when you're starting out, to be safe and evaluate your mastectomy flap. I think one of the other things that I just wanted to query Kyle and Lily on is at your respective institutions, what would you say the spread is as far as doing prepectoral total muscle coverage or just two-stage with the AlloDerm sling? I would say at our institution, it's certainly changed over the last few years. When I started training, we were doing probably 50% total muscle and 50% ADM, two-stage. And now I think we're probably doing around 80 to 85% pre-pec. And a lot of those are direct to implant. And there's only one surgeon who regularly does total muscle coverage. So a lot of our residents go through training nowadays without even having seen a total muscle coverage prosthetic breast reconstruction procedure. And I just wanted to get your thoughts on what the experiences were where you guys are.
So at Duke, we rarely do direct to implant. There's definitely been a change since the beginning of my residency where we almost did exclusively AlloDerm use behind the pectoralis muscle. And now we have several surgeons that are doing pre-pec expander or implant placement. And we do also a lot of pre-pec tissue expanders leading up to autologous reconstruction, since we do most of our autologous reconstruction delayed.
Yeah, I have similar kind of thoughts. Like I said, we had probably mostly 80% AlloDerm sling submuscular and then 20% probably total muscle coverage when I first started. Now I'd say it's probably 65, 70% submuscular with an AlloDerm sling, and then maybe 20, 25% pre-pec with maybe a smattering 5% or less of total muscle coverage. And I think, Raj, you hit it on the head. There are residents who go through that have very rarely see a total muscular coverage for a tissue expander. And I think it just kind of shows, even in the 5-6 years that I've been here, kind of the shift in how we deal with placement of tissue expanders.
No, that's great. And I just find it very interesting because certainly at some institutions, including ours, you can go through your entire training and rarely do a total muscular tissue expander. And then you may end up at an institution where the AlloDerm is, just because of cost issues, are really encouraged to use it. And then even for a prosthetic breast reconstruction, you're kind of starting and reteaching yourself the basics. So I just find it interesting how this technology has evolved over time and how much it's influenced us at different institutions. So, Dr. Slezak, I wanted to just get any last thoughts you had on this paper, or just on total muscular coverage versus AlloDerm in general.
Well, I think at Maryland, total muscular coverage is not seen at all anymore. And I think of the 4 surgeons here, most of us would do some submuscular probably 60 to 70% of the time. One of the 4 does prepectoral almost all the time, but we would use each technique selectively. I think what will be interesting in the future is as we get, single payer compensation for a diagnosis, And if a certain lump of money is given by an insurance company to do mastectomy and breast reconstruction, it could very much change our practices as we know them now.
That's an excellent point. I think bundled care payments are on the horizon. They've already started with joints and cardiac care, and you would imagine it's only a matter of time before it hits us in a lot of the areas of plastic surgery. So definitely something for everyone to keep an eye on in the future. I think with that, we will end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune into the other 2 articles that we will be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we'll be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page, and if you've not already done so, it is there where our monthly journal club takes place. And once again, thank you so much, Dr. Slezak, for joining us today.
You're welcome.